ready to build resiliency, create a healthy lifestyle, and overcome adversity with a warrior mindset. This is Define the Fight with Mariah Prussia.
Hey, happy Monday. We are back at it, and we're talking about resiliency. But, to build resiliency, you also have to make sure that you have internal health. And far too often, I'm a firm believer that we have changed the norm. And what is the norm? Well, it's shifting more towards, hey, what pill can I take? What prescription is next? And what I love is the fact that the individual that I have joining me today, she is the owner of Firefly Medical. But you know what? She has such a diverse and educated background that it's great to hear that you can have an independent doctor who has different views on what true health really is. So not only was she top 20 under 20 at the age of 17 for creating a nonprofit camp for underprivileged kids, but she has her Bachelor of Science in both biochemistry and physics. She also is an MD and PhD in pharmacology and therapeutics, specializing in insulin resistance, metabolic syndrome, female hormones in pregnancy, and the list goes on and on. But I tell you what, she is also, she was recruited as an educator for the Mayo Clinic, Max Ratty College of Medicine, as well as the University of Washington School of Medicine. So when I say that she has knowledge, man, does she have knowledge. So please welcome you guys, Dr. Nicole Levitt, to the show. Welcome on this fine Monday.
Thank you so much for having me.
Oh, I'm excited. When I first learned about you and briefly spoke to you on the phone, hormones are a really big deal. And, with personal training for the last 20 some years, my clients who were at the perimenopause, premenopausal phase are like, Mariah, just wait till you get to be our age and you'll understand. And now that I'm like, I feel like I got hit by a truck.
Yes.
So, let's talk about your background and what really brought you into the health industry.
So I was privileged that I knew what I wanted to be as soon as I could talk. I talked about becoming a doctor from the age of 4. My background in my interest in science started very young. So as soon as I graduated high school, I knew I wanted to stay in studying physics and biochemistry because I loved problem solving and I didn't want to give up the physics. During that undergrad, I learned a lot about problem solving, investigating, reading. And then when I went into medical school, I brought that background in with me. And that's why I got recruited to the PhD program, because I was inspired by one of the tutorial leaders who was discussing the pathophysiology of what happens before diabetes. And that got my attention because I thought, you know what, I haven't heard a good explanation for that yet. And so that ended up putting me into the PhD program where I really focused on drug science, drug development. And unfortunately, when you actually read a lot of the studies on drugs, you become very skeptical that why was this drug approved? Look at what a crappy study that was. Look, it was only studied for 6 weeks, but we use it for years. Like, that doesn't make any sense. And so you very quickly learn that a lot of the prescriptions that you're taught to prescribe as an MD actually aren't benefiting your patients.
So you had spoke about, too, the fact of when we look at the different prescriptions, why is there such a big push? And I know when you look at pharmaceutical, there's money to be made.
Yes.
I know that it's a horrible way to look at it, but it's fact. It's reality. So when you have patients that come in and you're looking at, holy smokes, look at all the different things you're prescribed. How do you, break that down for each client? Like, okay, hold on, let's take a deeper look at this.
Well, unfortunately, when you go to your PCP as a woman in perimenopause, you have multiple hormonal symptoms. A lot of them overlap with anxiety, depression, insomnia, musculoskeletal pain. And so instead of approaching you as this is a hormone cause until proven otherwise, which it is for the majority of women, they say, oh, you're probably anxious and depressed. Here's a psych drug. Oh, your bones hurt. Here's cortisone injections, or you need to be less active, or here's a painkiller. Instead of actually going down and saying, wait, in perimenopause, we see these hormonal changes that cause all of your symptoms, like low progesterone and thyroid abnormalities.
And I didn't realize some of the different, when you're looking at the hormones. So I started to have the different sensations of the tingling of the hands and the feet, headaches, so on and so forth. And I actually went to a naturopath in regards to having my blood work taken. And then when I went to like my yearly exam, I just asked my doctor at that point and showed her my blood work. And she goes, Mariah, I'm going to be honest with you. Your ratios look good, clearly, except for your antibodies. She said, we would have probably never taken your blood work for antibodies, and we would have looked at your thyroid and said, okay, everything looks good. So, explain how important it is for individuals to have certain tests taken if they're feeling different things like this isn't normal for me.
So what's taken over medicine in the last couple of decades are guidelines. So guidelines are written by experts in the field, and they're heavily biased by the pharmaceutical industry. And they become the standard of care, even though inside the guidelines themselves, they say don't use this as a standard of care. It's not. Those guidelines around hormone therapy are very biased and myopic, meaning they look at a tiny amount of studies and they're not looking at quality of life. They're not looking at the older studies where we used to treat thyroid based on symptoms, not based on lab values. And currently, the thyroid guidelines say you cannot treat a patient for thyroid disease unless they have hypothyroidism, which is defined as a TSH above 10. The TSH is a blood test that is showing how hard your brain is telling your thyroid to work. It's not measuring your actual thyroid levels. And there's a lot of disease that happens in normal range all the way up to 10. And we're taught that that doesn't matter because the TSH isn't above 10, there's no thyroid problem. That's the only hormone we dose based on an effort hormone and not the actual active hormone. And so when multiple of my patients have come in having had their thyroid tested for years, based solely on the TSH, and the TSH does not correlate to what you actually are making or how you feel. So who cares what your TSH is?
So when you're looking at your TSH and you're seeing patients that are coming in, now are they coming in on meds or not on meds?
The majority are not on meds, and if they are on meds, they're on the synthetic version of thyroid, which is called Synthroid or levothyroxine, which is only storage thyroid. And so the culture in the 60s and 70s, when they moved away from natural thyroid, which contained pre-activated thyroid T3, they moved towards this new product without it being FDA approved and without there being a trial showing it was better. They decided that if the body was to receive the inactive version, it would make what it needs. And that's sort of ridiculous because endocrinology focuses on organ failure. And if you're a type 1 diabetic, you can't make insulin. You have to get it or you die, basically.
Right.
But in thyroid, we're like, oh, if the body needs it, it'll activate it. And we know that is not the case, but that's the dogma behind the guidelines.
100%. So when you're looking at that, now what are different ways or you're looking at for individuals who are coming in that, okay, they need some type of hormone treatment or therapy? What are your guidelines or what are you typically, moving individuals towards?
So we start off with a very comprehensive history. And we go back to childhood, especially with women. We go through their obstetrical history, and we try to figure out where things went off the rails for them. Women with PCOS, that's the most common endocrine disorder for women, usually have symptoms of hormone problems going back to childhood or adolescence with, painful periods, PMS, things like that. Other women are fine until they hit perimenopause. And perimenopause is actually a state, from where I was trained, we call it no man's land. No one knows what to do, right?
Right.
Everything is normal in perimenopause. And the actual dysfunction in perimenopause is the loss of a hormone called inhibin, which regulates how much estrogen you can make. If you have high estrogen, you get bloated, you get acne, you get mood swings, you get heavy periods. That's the perimenopause. And then if women can escape those symptoms, if they get to menopause, that's when they'll start the weight gain and more mental health issues from losing their estrogen.
And I'm looking at mine in regards to ratios again, because I'm in that phase or in that bubble where the ratio of testosterone and estrogen is low. Mm-hmm. So my testosterone levels are great. It's the estrogen that's low. So what are the different things when women are looking at low estrogen? What are you commonly seeing a lot of in regards to those symptoms or signs?
So low estrogen generally shows up as high cravings for sugar, visceral fat, belly fat gaining. Usually your musculoskeletal system will start to ache more, like joints like hips, knees, shoulders. You can start getting more depression symptoms as well. Unfortunately, our culture, we've been taught that testosterone's for men and estrogen's for women. Mm-hmm. And if you actually look at the lab values, we have 10 times as much testosterone as estrogen when we are before menopause. And we actually need both hormones replaced. The hormone that's actually female is progesterone.
I think a lot of us who are not in the the health industry from a doctor perspective and the research that you have put in the years of time and effort and continue to, it's very important for us to question where we are getting our knowledge and where we're getting our education and our insight from. And I know this morning I was on our sister station, The Flag, and that was one of the big questions too, is how do we research something and know that it's fact or not, right? Because anything that we put, the analytics are going to put certain components at the top of the list on Google. So that's the first question, is what are some great resources for people to go deeper in regards to knowing more about their health?
That's a really tough question to answer because there's so much snake oil in this industry. And there's a lot of people that are touting things that are not true. And one of my biggest pet peeves is transdermal progesterone. So people think that they're protected if they have a cream of progesterone that they put on their arm. Transdermal progesterone does not create blood levels at all. It creates salivary levels. And therefore, you're not getting any protection from it. But there's providers in this state, I see it all the time, that are prescribing it. And so they're not taking their information from the medical literature. They're going to a course and taking everything that that person says as the truth and then practicing that way. And we see that in pellet providers that are trained, the thyroid is important. So they just pellet their patients with high doses of testosterone for women and say, here's a tiny dose of thyroid that will make you actually feel worse. So the big part is you have to go to someone who has the right training, and you should actually try to read some of the literature or the materials they provide you with. So when patients ask for information, we have an education booklet that we provide them that has a bunch of literature cited. And we also tell them, if you're really interested in, let's say, estrogen and breast cancer, here's a book but written by an expert on this topic. Testosterone in men, here's another book written by an expert, so that they're given good resources. And it's really hard to find that on your own.
Oh, yeah, because the thing is, we're at the quick fix. So let's find it. Google. Google is the new form of research when it really isn't. It's like, again, you never know who's controlling it behind the scenes. So I think it's important that you, like you said, are there a couple different authors or doctors or experts that you'd want to share for people to research?
Yeah, I think one of the lead experts for testosterone in men would be Dr. Morgenthaler. He's a Harvard-trained urologist. And then Dr. Blooming is a breast oncologist who's an expert in estrogen. And the list goes on. I'm happy to share a list with you if you want to share it.
Absolutely. I will share that after the show. Now, I want to talk about more in regards to, we look at different phases when it's perimenopause, postmenopause, all these different components and different ages when we start noticing different changes within our body. What do you think some of the biggest things or signs that we miss? And then I also want to know a little bit more after you meet with a patient or a client. What are some different hormone therapies that are more natural or that you would suggest versus what is currently being pushed?
Okay. So I'd say, and I'm going to stick to women for now.
Yep.
So women go through their first menstrual cycles. That's a huge transition point for women's health. That's usually where symptoms of PCOS will start for some women. So that is going to show up as possibly weight gain that's inappropriate, heavy periods, painful periods, PMS, and neuropsychiatric symptoms like anxiety and depression around your cycle. At this current stage, most women will get put on birth control as a solution to that. So the solution is shutting down your ovaries rather than balancing the hormonal problem. And then as women get into their 20s and 30s, usually they'll have pregnancy-related hormonal changes. In pregnancy, your body pumps you full of hormones between your ovaries and your placenta. When you're not pregnant, your estradiol level might be 200. When you're pregnant, it could be 6,000.
Wow.
Your progesterone level can go from 5 to 500. So your body is pumped full of hormones for months. And then as soon as you deliver your baby, the placenta detaches afterwards and your hormone levels plummet. And so there's a huge number of women that develop postpartum depression, anxiety, psychosis, and it's likely secondary to withdrawal of progesterone. And that's how we treat it naturally instead of the $25,000 a month synthetic downstream metabolites of progesterone.
Right.
After pregnancy, then you enter perimenopause, which, as I mentioned before, is a period of time where you have high estrogen, low progesterone. High estrogen can also impact your thyroid in that it can block conversion of your inactive thyroid to the active form, so you can get thyroid symptoms. It's also a time in your life where you're more likely to develop autoimmune thyroid disease. And then as you make that transition to menopause, you've likely also lost your testosterone somewhere between having kids and perimenopause. And then you become menopausal, your estradiol levels go to 0, and now you're in a state where your ovarian function is no longer there. So unless you supplement those hormones, you can't make them anymore.
So when we look at supplementation of hormones, there's so many different things that are out there, right? Different research, different studies, different prescriptions, so on and so forth, that people are pushed towards.
Yes.
When you look at hormone therapy, what are your best suggestions for, like, again, we're talking women. What does that look like?
So in terms of the menopausal transition, if you were to go to your, generally speaking, if you go to your PCP, they will offer you either synthetic hormones, which would be Previn and Provera. Those have much higher risks than the bioidentical versions, which are estradiol and progesterone. Or they might offer you a commercially available bioidentical product, which would be a very, very low dose and usually only transdermal estradiol, which if you take estradiol transdermally, you're missing the first pass metabolism of the drug through your liver. The first pass metabolism generates metabolites that eat plaque and reverse aging in your cardiovascular system. So women might be put on hormones and then they won't get all the benefits if they're put on the commercially available bioidentical product because it's such a low dose and it's the wrong route. Or they'll get put on synthetics, which carry risks.
Right.
What we do at Firefly is we have thousands of manuscripts that we've based our treatments on. And we try to take the best possible route of administration and dose to get the optimal results. So it's normal to be 0 in menopause. It doesn't mean it's optimal or healthy. So we try to make women go into the optimal ranges of those hormone levels. And we also know that there's another factor that's not going to show up in blood work, and that's signaling at the receptor level. So as you age, the receptors for your hormones age with you. So even if you had at 55 the same hormone levels you had at 21, the signaling would be less. So you actually need super physiological levels of testosterone, for example, to generate the higher sex drive than the level you had when you were young.
Which makes sense.
Yeah.
100%. So when you look at the different hormone therapies that are out there too, I know some of my clients have utilized the pill or the incision, right? Right.
Yep,
in
the pellet.
The pellet, right? In the glute. What are your thoughts on that type of hormone therapy?
So generally you're going to be pelleting for women estradiol and or testosterone. So pelleted estradiol it's the same downside to transdermal. You're not going to get the first pass metabolism, so you're not going to get any of the cardiovascular benefits. So great, you have some estradiol, it's good for your skin, you feel better, but you're missing out on the heart benefits. And if you look at what's the biggest killer of women? Heart disease. Yeah. That's what you need to go after. And you're not going to get as good of a benefit there. And then if you look at pelleted testosterone, I generally see women that are not happy with pellets because I don't do those. What happens is you put a pellet in the same woman, the same dose, 3 different times, she'll get 3 different levels, depending on her level of activity, the time of year, the blood flow past the pellet, where it was exactly inserted. So her levels will have a big swing. And generally speaking, women only feel good for a portion of the pellet when their levels are in the sweet spot. And if you use something you can control, like an injectable or a transdermal cream, I can keep you in that sweet spot all the time once we know what that sweet spot is for you.
And then when it comes to hormone therapy, is that typically a lifelong that individuals will stay on?
Generally speaking, yes, especially if you're talking about the perimenopausal, menopausal group. There are a subset of women that have a pregnancy-related hormone issue, and once their ovaries go back to functioning normal 2 years postpartum, they can go off and they're good. Sometimes it'll be a critical illness or a car accident or a traumatic brain injury, and they might go on and come off again.
Gotcha. Because the key thing, I get nervous when I hear lifelong, not necessarily from a hormone perspective, but there's different prescriptions where, no, this is a lifelong drug. Well, I would still, aim towards questioning that. We are here with Dr. Lovett from Firefly Medical, and she is absolutely unbelievable. Yeah, we've been having a lot of conversations behind the scene, but what's really important to understand is we are a very quick fix society on, hey, what can I take? It's not so much what can I do, it's what can I take? And it is a hot topic when we're talking about weight loss. And I understand there's a lot of different things that stem with when somebody is obese, right? When you look at anxiety, you look at depression, you look at the fact of excess weight on joints and what that does for the physical body as well. But when we're pushing individuals towards drugs, to increase weight loss, what actually is happening? I want to talk a little bit, there's a lot of different drugs that are out there, but let's talk about Ozempic, for example. What is your thought in understanding clearly the dynamics of the pharmacology and the breakdown of adverse effects?
So I think right now they're being used inappropriately. Not everyone is a candidate for them. In our practice, we try to figure out how we can lower insulin resistance in every other way: diet, exercise, important vitamins like vitamin D, which can lower blood sugar, and as well as optimizing other hormones that are maybe out of balance. Like a woman in menopause needs estradiol and testosterone and maybe even thyroid hormone before we even entertain something like Ozempic. Unfortunately, there's a lot of clinics that use it as a first-line treatment for obesity, or even as, I've heard you say earlier, someone who only had 5 pounds to lose was put on it. GLP-1 receptor agonists are what the drugs are, what Ozempic is, I should say. And it works by increasing insulin sensitivity and reducing the reward pathways between the gut and the brain. So you get less of a reward from eating foods that maybe previously you found really tempting.
Or satisfying.
Satisfying. It also delays gastric emptying, which improves how satisfied you are from your meal because your stomach empties at a slower rate. And if you think about those as the general mechanisms, when you give that to somebody who already has a thyroid problem and has a slow gut, those are the people that are getting gastroparesis or stomach blockages and needing to go to the hospital because you've slowed their gut down to zero. And you also have a group of people that will not respond to them because they have such a bad hormone problem that you can't get blood from a stone. If your metabolic rate is very slow, these drugs don't tend to work very well. Some of the other downsides are up to 50% of the weight that you lose is muscle. And we've been trying to fix obesity for decades, and yet it keeps getting worse and worse and worse. If we go back to a time period where we thought gastric bypass was going to cure obesity, we now know that it has a 5% success rate after 5 years. The patients lose a bunch of muscle. They develop addiction switching. A significant number of them become addicted to drugs, alcohol, gambling, you name it, because their drug of choice was food previously.
Right.
And yet we're using the same mentality. We just have to block the stomach from working properly, and then we can cure obesity. And unfortunately, in my experience, if we start hormone therapy first, maybe 1 in 5 patients will need it. Whereas if you put them on the GLP-1 receptor agonist like Ozempic, and then I get them later, it's really hard because after 18 months on the drug, it stops working at controlling your cravings. And after 24 months, you start to regain body fat if you haven't had other things fixed.
What are your thoughts in regards to, I know individuals or I saw an ad where it was posted on Facebook, where it was talking about a certain drug and the fact that, hey, you don't need to see a doctor. We can mail it to you. All you need to do is fill out an assessment, and it's going to be at your door in X amount of days, and you're going to lose weight and feel great. What are your major concerns when you're looking at the fact that now you're taking one line of defense out of there, and it's like, okay, it's a free for all for everyone.
Right, and that's it. In that case, you should make every drug over the counter then and take the provider completely out of the equation. There needs to be a therapeutic relationship between the person prescribing a drug and the patient. And if there isn't that relationship, then it's extremely unsafe because people who have contraindications, like genetic cancers in their family, that they can't take certain weight loss drugs, might get that drug and get cancer from it. Or maybe they have a reason not to be taking it, like they're breastfeeding and they can't take it. And so when you have companies like that are bypassing the therapeutic relationship, in my opinion, I don't think that's even permitted by, statutes at the Board of Medicine in multiple states.
And it shouldn't be if it is, right? Yeah. So when we look at prescription drugs, this is a hot topic also, and a lot of people are talking about incentives.
Yes.
So when we look at doctors that are prescribing different components throughout to patients, let's talk about, the quality metric of what that looks like.
So insurance companies like to use quality metrics to reimburse health systems. So if we go back to the guidelines are a group of experts heavily influenced by big pharma as well as their own training that we should keep doing what we're doing because we're good at this, despite the outcomes showing that we're not doing a good job. So then those group of people set the guidelines, and then insurance companies use those guidelines to decide if I'm a good doctor or not, if I'm working in insurance-based care. And an example of this could be a statin drug. So if I have a certain number of patients that have been labeled as diabetic in the computer and I don't prescribe them a statin, I will get a lower reimbursement on my bonus because I'm not hitting my quality metric. So they try to hide it behind quality metrics because they're not allowed to tell me what I'm supposed to prescribe. But they can incentivize that if I'm a good doctor, I follow the guidelines. Regardless of maybe 100 of those diabetics are not diabetic anymore because I put them on a carnivore diet and now their A1Cs are normal and they don't need a cholesterol medication.
Which is crazy, right? So when we look at the fact of, I think everybody is starting to recognize too, is that do we really want people to be healthy? That should be the question, because if we really wanted people to be healthy, then we would be doing something different than what we're currently doing, right? We're overprescribing people, and then we're settling into this mindset of quick is better instead of doing the work is better. And that's the problem. So when I'm looking from a physical fitness perspective, right? How many people are actually exercising? You can't out-exercise poor nutrition. You just can't, right?
Nope.
You have to have quality foods. And we can all agree that the quality of our foods, the nutrients that we're getting, is less because there's more chemicals that are being used, right? And the soil is basically dead in a lot of different areas. So when you see these different things, now, as an independent doctor, are your quality metrics impacted as much as other doctors in regards to larger organizations?
No, because when you take insurance out of the mix, so all of what we treat for is quality of life. That's our outcome. And it's just a side effect that when I'm treating you for your quality of life, that your A1Cs get better and you aren't a diabetic anymore. But our goal is quality of life. And so we exist outside of insurance. So it doesn't matter what the guidelines say. It doesn't matter what insurance companies are saying. It's just me and my patient in the room. What do they want from their treatment? How am I going to get them there? And what are they going to do to help them get themselves there too?
And you mentioned carnivore, and I've shifted towards carnivore. Let's talk about the benefits and why you feel this is, imperative or essential to individuals. It's strict. Some people can rock it out, but there's also different modifications of the carnivore. So let's talk about your thoughts on that.
So I consider carnivore under the umbrella of like a therapeutic carbohydrate restriction diet. That also happens to be extremely anti-inflammatory because when you remove all the plant toxins, then you have a very anti-inflammatory diet as long as you don't have a meat allergy. So there's a spectrum here. Some people do better on a ketogenic diet, which is high fat, low protein, or some people can't tolerate the restrictive nature of carnivore, even though it's really easy. It's if you could have killed it and dragged it home, you can eat it. That's
right.
The rule. Some people will go on a low carb, high protein diet where they're really eating more proteins, but they still have some of the vegetables in there and and trying to avoid the sweeter foods and the starches.
So when we look at the different type of diets and the different shifts and the push, right? So you hear a lot in regards to, I understand vegetarian, vegan, so on and so forth, right? And everybody has their own different thing that they gravitate towards that works for them, which is great. But when we start seeing pushes of getting away from animal-based in strictly plant-based diets, what is your view? Because you said eliminating the toxins from the plants.
Yep.
Let's talk about that.
So 99% of plants are inedible and 99% of animals are edible. If you had to guess and you were starving on a desert island and you're like, should I eat this plant or should I kill this animal and eat it? You probably should go for the animal because the odds are in your favor that you're not going to get killed by the plant toxin if you eat the animal. The push for plant-based diets comes from a marriage between big agriculture, big food, as well as big medicine, because plant-based diets have a almost 100% reversal. Most people will quit them because they have so many meat cravings, they get tired, they get anemic. It's not really a sustainable weight loss strategy for most people. And so you're setting up the patients to fail. And you can also own the food. So it's really hard to patent and own an animal, but you can patent and own a strain of wheat or soy. And so it's much more profitable to package up processed plant-based foods that are not whole foods instead of telling people to eat meat, which will naturally improve their Ozempic signaling in their own gut by 15 or 20 times.
Again, each thing, isn't it amazing how it all circles back to money? Before we dive into how individuals can find you, let's talk about the food pyramid. Let's talk about cholesterol because, I read a study too in regards to the cholesterol numbers were actually significantly higher, years in the past, and then all of a sudden it shifted. So let's first start with cholesterol.
So there was a very flawed study done by Ansel Keys that showed that heart disease correlated with LDL and total cholesterol. He cherry-picked the countries to make the correlation. If you actually correlated it with sugar intake, it correlated with sugar intake, not LDL. And so all the studies, all the research in the last 50, 60 years has been focused on LDL being the problem, bad cholesterol, quote unquote. It's like flat earthers though, because every time they run the study, they discover it's not LDL that predicts heart disease, it's your triglyceride to HDL ratio. So your triglycerides are produced from sugar, your HDLs are good cholesterol, and that ratio being above 2-to-1 indicates insulin resistance, which then causes the heart disease. So if you see a rise in your total and LDL cholesterol, but you have a low risk triglyceride to HDL ratio, you are doing fine.
So when you look at the numbers, what would you say? And again, it's the ratio, right?
Yep.
But when you look at the numbers, should people be worried if they're over a certain mark? I mean, again, after looking at the ratios, because there's a big push where it's like, oh, you need to go on a cholesterol medication now, right? So what is a good way for an individual to be an advocate for themselves when they might feel like their back is pressed up against the wall when they're meeting with their physician?
Well, I can say one group right off the hop, women who have never had a heart attack or stroke that have a low risk ratio of triglycerides to HDL do not need to worry about their cholesterol. They will likely live to 100. Those women, for primary prevention, meaning that you've never had a heart attack or stroke, they increase their risk of dementia, breast cancer, colon cancer, and diabetes. And they never had a problem to begin with, necessarily. Every person has to decide what kind of prevention it's for and what their other risk factors are. But at the end of the day, you're way further ahead getting your triglycerides down through diet and exercise and hormone optimization if you have a hormone problem than you are to take a statin, which will raise your triglycerides, increase visceral fat, and increase your risk of diabetes.
So what I'm hearing in everything that you're saying, it's all based off hormones first, like is the seed. And until you can identify really what's going on there, stop masking problems by adding different prescriptions or different things into the mix.
Correct. If we make your lipid panel look better, but you're worse because you put on 30 pounds of belly fat, what did we do? We didn't help you.
Right. And then speaking of putting on belly fat, so on and so forth, looking at what the food pyramid used to be and now how it's shifting, you had a thought that you wanted to share in regards to that.
Yeah, so the food pyramid is actually upside down. We have all these carbs and grains and vegetables at the bottom. We should invert the food pyramid, and animal fats and proteins should be the basis of our diet. And we should eat those foods very sparingly that have starches and sugars in them.
I wholeheartedly agree. And when I was talking to one of my clients too, I shared this with them. When you're making bread, when you're making it, right, it starts off as a small ball. But what happens when you put it in the oven? It expands. So as it expands, what do you think is going to happen if you're consuming a lot of bread? You don't think that your body is going to expand and experience different things. And if you're not sure what your body is sensitive to, do an elimination where you're slowly eliminating something, have a control factor, but then also be able to see like, okay, the bloating is gone. Oh, I don't have gas now, so on and so forth. Was it from the starches, right? So, I did a candida diet way back when. And what I recognized too is that my body was sensitive to breads, but then also to dairy and also to like fruits, and then I introduced him back in and it was like, boom, all of a sudden it's like, wow, hold on a second here.
Yeah, and the other factor too is a lot of the processed foods have seed oils in them. And seed oils are things that you couldn't fathom how they got the oil. Like, how do they get vegetable oil? Vegetables don't have oil.
Right.
It's a chemical reaction. And they used to be used as industrial lubricants until someone thought, well, why don't we sell them to the processed food industry? We can put them in the food. Seed oils are similar to carbohydrates. They increase human appetite and addictive behaviors around food. And that's one of the strategies around Ozempic is to use more seed oils because it'll make it work less effectively. So that's why it needs to be whole animal products, whole healthy fats like avocado, olive, things that are naturally fatty, not the synthetic oils.
So when you have individuals come in, what are some of the main focuses? So at Firefly Medical, what are the services that you provide? Because clearly you have so much knowledge, and I want to make sure that individuals who right now are clueless or like, wow, hold on, I had no idea, that want to learn more. What are some of the services you provide?
So we provide medical weight loss and hormone optimization, as well as some medical aesthetics like neuromodulators, sparingly dermal filler and facials, microneedling, that kind of stuff. But our main focus is hormone therapy and improving people's quality of life. So if you're struggling with, I can't lose weight, I have depression, I don't have a clear trigger for, I feel anxious, I never felt this way before, I'm not sleeping anymore, those types of things could very well be a hormonal imbalance. But if you go to a doctor that is not, or a provider that hasn't been trained in this, they're going to usually dismiss your symptoms and give you something like an antidepressant or a statin when you really need thyroid hormone.
And where are you located? Because you've got multiple locations.
We have a location in Grand Forks, North Dakota, Fargo, North Dakota, and then Liberty Lake, Washington.
Awesome. And what is the best way for them to get a hold of you?
Usually through our website. They can email in, which is fireflymedical.net, or on social media, and our handles are at Firefly Medical.
You know, it has been an absolute honor listening to you. I could talk to you for hours. But you know what? It's great to hear as a doctor, you have different views in regards to how you perceive, what is life, what is health, and how you want to educate your clients and patients even more. Because really, it's about giving and empowering and educating individuals to be their best advocate. Because we are in a pivotal time within this world. So again, go to fireflymedical.net, learn more about Dr. Lovett and all of their practices, because you know what? We all need to learn how to define our fight, and it all starts with education and our health. So until next week, get out there, get after it, and define your fight.